And it's really great pleasure to have over from the Netherlands Cancer Institute, Heinz-Josef Klumpen, who is going to tell us about testing. Welcome, Heinz-Josef. You've heard from him already.
Thank you, John. So I have the privilege to discuss this item. It's interesting because when you get to know a technique via medicine, then you have to go into detail yourself if you have to give a presentation about the technique itself. So I work in Amsterdam, and I have the privilege also to be the subdomain leader of the EuroCan, which is the collaboration of hospitals specialized in this disease. So these are my disclosures. So personalized medicine, that's more or less what it's all about. So the targeted and personalized medicine, that was the goal for the last decades in cancer care. And the question we have to answer today is, have we reached that goal for biliary tract cancer yet? Fortunately, Juan is talking more about the personalized medicine, so I don't have to go into detail, but I will talk about the tools. Talking about Juan, yes, he was involved with this study, and that was the landmark study for palliative care in this disease. 2010, it was published and has been and is still the standard of care for first-line treatment, and it is for all biliary tract cancer. So personalized medicine was not involved in this one at all. So what has happened since then? Well, we had a look back, or many people had a look back at how can we be more precise in personalized care with this regimen. So like stage, anatomic subtype, patient features, blood test, and also later genomic tumor profile. And as you've seen, there are many publications, these are just three mentioned here below, on what sort of features are the best to choose the right patient to be most effective with this treatment. Well, then 2017, this landmark study came, and that has been published and showing what we have aimed for with all the other cancers already. Like with breast cancer, we know all the subtypes. And so what they've done is they have had a look at clinical features, but also the genetic profile of biliary tract cancer. And it showed not only that there are 4 groups, but also that they have a different prognostic outcome. And as you see, that the prognostic outcomes are very much also relying on the genetic profiling. So the people came aware of this, and we had to do something with it. And so Juan is talking more about the consequences of those features in treatment, and what I will talk about more is what is it actually. So the molecular profiling is the analysis of the DNA of tumor cell nuclei, so in the DNA of the tumor cell. So not of the host, but really the tumor cell itself. And the commonly used terms are here next generation sequencing, for example, the NGS or whole genome sequencing, differentiating just a panel of, for example, mostly used or targetable mutations or amplifications, or the whole genome. So just to get back in history, since the 1990s, there was a big movement, and that of course started when the whole genome of the human body was found, or that was a multinational, multi-billion dollar thing. And then over the years, the technologies became easier and easier. So they called it then, by the way, the massive parallel sequencing. That was the first term. In 2005, the testing became commercially available, and then the price dropped tremendously. So in 2007, it was about $1 million, and most recently, it's in the hundreds of dollars per test. It can be cheaper even. And of course, the implementation was depending on the tumor type, because for some tumors it was very important because drugs are already available. The example here is the lung cancer, and as you see, it's country-specific which panel is used. So UK is here with a small panel of 4 mutations. In other countries, there are many more. And so, of course, depending also on the availability of the drugs responding to that. The healthcare cost impact is also not to underestimate. This is just what I found on the internet, just to get an idea what the development will be in the future. So the cost right now, if you have a look, 2023, it will be about $8 billion, and it will be much more in the 2030. What is the impact for biliary tract cancer? So there are many publications on this. If you search the literature, many reviews showing what subtypes have which mutations. And when you see, so the gallbladder, the HER2, for example, is an important one. TP53 and KRAS are very common in most biliary tract cancers. And for the intrahepatic, that's more or less the most interesting part of that disease, where you have IDH1, for example, also FGFR mutations, and these are very promising, as Juan will show you with the treatment. For other extrahepatic cholangiocarcinoma, other mutations are present, where there is less targets to find yet, I would say. And just this is a publication we did ourselves from, just to give a review of about publications, just to see what the frequency is. It's about 1,800 patients. So the intrahepatic cholangiocarcinoma, that's the disease where the most targets are, and here depicted in the size, and the size reflects the frequency. But also on the right side, you see that the frequency per tumor type. So these are just different ways to depict the same thing, more or less, that each tumor anatomical subgroup has a different pattern. And why is that? So as our pathologist showed me, that's actually a logical thing because of the way our body has been developed from the embryonal stage. So we have two parts, the pars hepatica and the pars cystica, and they give birth to two different parts. The hepatica more to the liver, the common hepatic duct, and the intrahepatic bile ducts, and the cystica more to the gallbladder and the bile ducts itself. So then you understand why there is a genetic diversity here. You can look a nice YouTube movie about it if you like. Also, something has been presented here, I can remember last year, I suppose, from pathologists who says, yes, you can do genetic testing, but just histopathologically, just by looking at it, you get also a hint, because there's a small duct and the large duct types, and they predict if mutations are present or not, as you see here. So the small ducts are more likely to feature IDH1 and FGFR2 fusion. The most recent ESMO guidelines say a sentence about this subject. So they say nearly 40% of patients, which is very high for cancer, harbor genetic alterations which are potentially targets for precision medicine. Therefore, molecular analysis should be carried out before or during first-line therapy to evaluate options for second and higher lines of treatment as early as possible in advanced disease. So that is a very clear statement, I suppose, and need to be implemented in all countries, I suppose. With thanks to my pathologist, Professor Fahey, I show you some pictures from the practical point of view, because we doctors, we get results in the computer system. But how does it actually work? And I thought it would be interesting for you to see. So what they do, they cut out in the pathology room, they cut out the pieces, the biopsies or resection material. They put them in these boxes, they fixate them, and then they cut out little slices from the fixation. These cut out slices will be put on a glass, and that glass will be stained, as you see on the right side. And then they look at it. So there are some steps in between. And the success of molecular diagnostics are depending on how the tissue looks like. And not going into details, but you just see that they're looking different, and you see some tumor cells here and there is lots of, for example, for cholangiocarcinoma, there's lots of non-tumor tissue involved as well. And so to have a good result of the molecular diagnosis, you need to have 20 to 30% of the tumor cells in your to be tested specimen. And some techniques even show if you have less than 10%, then it can be done. But to improve that, we need macro and micro dissection. So the yield of tumor cells need to be high. And that's lots of work for the pathologist, but that needs to be put in the back of our mind if we ask for tests. That it's not just a test like a blood test. For biliary tract cancer, of course, there's also the bile duct brushing. So a lot of patients are diagnosed via the ERCP. That is very challenging, and there are some improvements over the last years. The yield is higher, and the amount of cells we need is getting lower. So the harvest of tumor cells, that is the whole goal, of course, and for the pathologist, that the quantity and the quality is sometimes poor. And that's also because there's lots of inflammation involved as well, ulceration because of stenting and all that stuff. So there's a low sensitivity but a high specificity. A liquid biopsy and tissue NGS is, so here that just depicts on all the options. So we can do via ERCP, via blood, via biopsies and resection. These are the four most common features. So general consideration, the tissue quality, so the fixation times are important, and most of cases we get the samples from elsewhere, so we have no influence on that. The transport from other hospitals, it sounds so easy, but that's one of the biggest hurdles for us so far. We don't have a good system, we just rely on the mail, just the post, and that means that takes time. And the time, because every hospital has a different way how it works, how they send it away, that can easily take 2 weeks. And of course, also the time frame of biopsy and fixation, so that's important. Also, when a patient with a tumor in the liver is diagnosed with cancer, a lot of doctors think of an adenocarcinoma of unknown primary. And the amount of stainings and tissue for the diagnosed need to make a diagnosis is taking a lot away from the tissue we need later for the NGS. So that's a subgroup, especially for the intrahepatic cholangiocarcinoma. Just some results from the SPECTRA study, because that was a recent thing, the ER2C initiative of rare cancers. The conclusion was that molecular profiling should be performed in all patients diagnosed with a rare GI malignancy, not only intrahepatic, as soon as advanced disease is diagnosed using a wide gene panel of NGS technique. Juan will go more into details about the consequences of the mutations have been found, just an overview, the historical overview of the options, and of course the most recent with pembrolizumab. The ESMO guideline, I understand Juan will also go into detail, so they already adapted mutations and treatments. More detail. So are we there yet? Well, we still have some challenges, but I hope to give you a solution as well. So the questions are how to finance molecular profiling. In the Netherlands this year, all medical oncologists agreed to each other that we have to get finance. So there's a committee sent from our group to talk to insurance companies and the government, because we think this is a crucial thing and prices only will go down the more you ask for. And it will also have impact on how we use pathology to start with, as with what I'm just saying. So how to determine the panel? That is something which will be work in progress, because each year we have new insights and the panels and the potential treatments. How to improve benefit? That is in RCTs. So how do you actually do a good concept of, so we need new ideas how to do clinical trials. And people in the room have thought about this, so I can present that. So what's the role of liquid biopsy? I think that's a very evolving thing, and we have seen with the TAS 120 publication in the New England Journal of Medicine this year, where the pathology NGS and the liquid biopsy NGS was nearly overlapping. So that is a very hopeful thing. But the technique has to be implemented in the hospitals, because we need this, because biopsies are difficult to take in this disease, at least for the extrahepatic diseise. What's the role of preoperative and adjuvant setting? That is a huge field we have no clue yet. And please fill in if anybody has any good ideas on that. There is something which came up in a meeting last week, which I want to share with you. So there was a genetic specialist involved, and she said, so has family counseling been implemented? I thought like, oh, that was a black spot for me, because we ask for NGS, but sometimes we find germline mutations, and that has consequence for the patient and his family. So that was, I wanted to share that black spot with you. And of course, the best timing of NGS. Well, the statements so far are very clear. The earlier, the better. But I guess we might need some more insight in that, if there is a big change and if that has therapeutic consequences. Well, solution, the Sapphire study, I guess, would be one of the solutions. And I'm glad that not only be available here in Great Britain, but also we have the hope to get the European grant to have that study implemented in other countries as well. So how do we do that in the Netherlands right now? It's not standard of care. It's not in the guideline. It's not reimbursed by insurance company, but most hospitals do use it because we have it available for other tumor types. We preferably use it as a part of a clinical trial, for example, the pre-screening, and we finance it ourselves, because the more we do, the cheaper it is. In my hospital, if eligible, patients are pre-screened in ongoing clinical trial, and they all participate in the liquid biopsy biobanking we have implemented. So my conclusion, I hope I'm good in time. Molecular profiling is a promising tool for personalized medicine, has proven benefit for subtype of biliary tract cancer. It needs implementation, and more RCTs are needed. I was asked to do UK and Europe, so this is my my UK thing. So I think the Sapphire study should be available for all patients with this disease in advanced stage. But I'm also aware, of course, that there are other pre-screening studies. And in Europe, well, the ESMO guideline recommends the use, but per country, it's different how it's implemented. Well, thanks to the opportunity to give this presentation, and of course, thanks to the team. And just to want to let you know, so this is the team in the Netherlands. So we have a collaboration of all centers, and it's not a lot because we have centralized care, but people see and talk to each other very often. So that's a way how we keep it centralized. Thank you.